Okay, hi everybody. This is chapter 67, and this is care of the normal newborn. So buckle up, okay? And let's get rocking. And I'm going to move my face up here. Okay. So the care and bond in the first several weeks of a neonate has many effects. In other words, it's really important that, the first couple weeks after that baby is born, that the mom and the dad, bond with that baby. There's something called skin to skin that's really important. And the bonding with the baby also has effects on the mother's recovery, believe it or not. As nurses, we have a special role of teacher and advocate for the family and the neonate. A neonate is the same as a newborn. Okay, that's what that means. Neonate is newborn. The first 24 hours of that neonate's life are critical. Some of the important things that go on are temperature regulation. The baby's body has to learn to self-regulate its temperature. That happens in the hypothalamus gland. Circulation, because up until the point of delivery, the circulatory system is very different because blood is shunted away from the lungs, right? So the baby doesn't breathe air in utero until it's delivered. Right. So it has to get circulation moving, respiration, and source of nourishment, food. So these are the important things that happen in those first 24 hours of life. In utero, there's no gas exchange across the alveoli, like I just said, right? As soon as that baby hits the air, whether it's a cesarean or a vaginal birth, as soon as part of its body hits the air, it's just instinct. It's going to start to try to breathe. Better if it cries, because that crying actually it helps to clear the lungs out, right? So it's more effective. So those first couple breaths that baby takes help with that conversion from that fetal circulation without any gas exchange to regular human being circulation, right? Gets the liquid out of its lungs because it's been in liquid, right? For the past 9 months. The circulatory pathway changes abruptly. Think about it. Once that baby's out, we put it on mom. We clamp the cord. We cut it. That's it. That's the end. Mom and baby are no longer connected. And that's when that circulatory pathway, suddenly that one ends and a whole new one starts. So imagine, it's a good thing we don't remember when we were born because it probably would be traumatic, right? Think about it. So let's talk about body temperature. Heat loss. There's different ways that not just babies, but everybody loses heat. So conduction, convection, evaporation, and radiation. And so we're going to talk about those real quick. Highlight that. Okay, so we'll start at the bottom. Radiation, radiant heat. That's when heat is emitted off of something. Think about old school radiators, like in people's houses, right? If you know them, they're filled with water. The water gets real hot. When the water gets hot, then the radiator gets hot, and that heat just kind of radiates into the room and brings the room temperature up, right? Evaporation, that has to do with fluid loss, right? If you put a glass of water on a table, eventually it will be empty because it will evaporate into the room, into the air, right? That's what clouds are, evaporated fluid that goes up into the sky. So when a baby comes out, it's sapping, soaking wet. And so it loses a lot of body heat just by virtue of the fact it's wet. That's why drying that baby off right away is really important, right? I'm not even going to talk about convection because we don't really convect heat, and conduction, here's a good example. Somebody sits in a chair and that for a while, and then they get up, and then you sit in the chair and the chair's still warm. Right? So that's conduction, right? You conducted your heat into the chair, and then I feel the heat when I sit in that chair. Make sense? Okay. So how does the baby maintain its body temperature? Well, the same way that we do as adults, right? When we shiver, if you're really cold, that shivering actually helps raise your internal core temperature. It's just an involuntary response when you're in the cold. Muscle movement, it's better if the kid's kicking and screaming. It is, because that helps regulate temperature. And the production of heat by using brown fat, which I'm not even going to get into because no one's ever going to ask you about that. Is the following statement true or false? It's normal for the newborn to have a respiratory rate greater than 60 breaths per minute. You guys can just nod your heads if it's a yes or if it's a no. you know. So, okay, 45 to 60, right, is about the respiratory rate for a newborn. The first couple hours after it's born, it's again, this is all brand new for this baby, right? This baby hasn't been breathing. So all of that's trying to self-regulate. So its respirations can be irregular, right? If an adult had irregular respirations, we'd be concerned. That'd be something that's reportable. But a baby is going to have irregular respirations, especially the first 2 hours, because it's just basically learning to breathe, right? And sometimes it sounds like almost like crackles. Why? Because there was fluid in its lungs, right? So it's still kind of working to get the fluid out. And also it depends on what that baby's APGAR score was when it was born. Because if it had a super high APGAR score, that means that when it was born, it's crying and kicking and all that stuff. So it gets all that fluid out quicker. If it was on the low end and it was just like, right, it takes a little longer to get all the fluid out. Okay. All right. All right. Goals for immediate management of the newborn. So you'll see, even when you watch videos, first thing they have a bulb syringe, right? That the snot sucker I used to call, and we suck the mucus and the liquid, the fluid out of the mouth, the nose, right? Wipe it dry, right? Wrap it up, skin to skin, right? Provide a safe environment. Routine preventative measures and promote maternal infant attachment. A quick note about that. If you have a mother who is a little complacent, in other words, not, most mothers are like, oh my God, let me see my baby. Sometimes mothers are like, oh, I've been in labor, I'm tired. Like, it's okay, support the mother, right? Sometimes everybody's different. Just like with the grieving process, it's the same with the bonding process. Sometimes it takes a minute. Right. So don't be like, oh my God, we better call DIFUS. Like, I don't know what's going on with this woman. She doesn't want to hold her baby right away. Give her a minute. APGAR score. And APGAR is an acronym, and it stands for appearance, pulse, grimace, activity, and respirations, or respiratory effort. It's always assessed at 1 minute after birth and 5 minutes after birth. Always. And the score determines whether the kid needs to be resuscitated. Hopefully it does not. Right? Because that's not great. And the highest score that you can get would be a 10. Okay. Here we go. Total score of 10, best possible condition. 7 to 9, it's in good shape, right? 4 to 6, I'm worried. 0 to 3, that kid needs to be resuscitated. There's a problem, right? And usually they will have somebody in neonatal, like on standby, in case there's an issue, right? Okay. If breathing doesn't start spontaneously, so if that kid's not out and crying right away, which doesn't always happen, then we do tactile stimulation. Not like we do on an adult. With an adult, we would do like a sternal rub or something like that. We don't do that on a baby. One of the things we do on a baby is on the bottom of its foot, flick the bottom of its foot, right? Or rub the baby, right? That's tactile stimulation, right? Tactile means touch. And sometimes that's enough to get it moving. Sometimes just when you start drying the baby off, it'll start, which is good. If it does not start breathing spontaneously after that, then the baby needs resuscitation, right? So you establish an airway, provide oxygen to the lungs, and hopefully stimulate the baby to breathe. That's never good if that newborn needs resuscitation. That's always a worrisome sign. So the birthing room or whatever, the suite in the hospital is usually set at about 75 degrees, okay? That baby can go into shock because it's coming from your body temperature. Your core body temperature is about 98.6. So it's coming from that in that nice, moist, warm environment and bright lights and people. Like I said, it's traumatic, I would think, right? Dry the baby quickly, warm towels, and usually they'll in birthing suites, they'll have a towel warmer. So they'll wrap the baby up. And they put those cute little like woolen type caps on the baby's little head. And during the assessment, they have pre-warm mattresses. So that little bassinet thing, right? That little mattress is warmed in there. And they'll have a radiant warmer also. And the instruments are warmed. Everything's warmed because it's a shock, for something ice cold to touch the poor kid's skin. And I'm going to highlight all of that because that's all pretty important. Okay. Clamping and cutting the cord. So baby's out. Hopefully it had a great APGAR score. It's on mom's chest right now. We're going to clamp the cord with Kelly clamps. They kind of look like hemostats. Clamp it in 2 spots. Clamp, clamp. Okay. The one spot's going to be cup at an inch or so from the baby, maybe 2 inches from the baby, and then another inch or so from that. Clamp and then cut. Okay. At that point in time, they'll usually take a sample of the blood from the cord. That part that's still attached to the placenta. Because remember, during delivery, baby's out, cord still attached, placenta comes out, right? So you've got the placenta kind of sitting there, right? And the baby's still attached to it. So once we cut it, it's done. And then we put a plastic clamp right on the baby, right by the umbilicus, and that's going to dry up and that's going to fall off on its own, right? And then we take the Kelly clamps off. Don't let your baby get stole. The baby gets identification bands and the mom, they're all matching. Okay. And again, this goes back to years ago, and it's truth that crazy people would sometimes go to maternity wards and steal babies. I'm the aunt. Can I just see that, my little Joey, or what? And they'd walk out the door with the kid. It used to happen. So now we don't let that happen anymore. So mom gets a band on her wrist. Baby gets 2 bands, ankle and wrist. And important to know that because that is a board question too. So make sure you remember that, right? And they will also place a band on the significant other, whether it's the dad or the girlfriend or whoever, right? And then whatever the number is on that band, it's all the same number and that gets recorded, right? And also they usually have alarms at the door and self-locking doors. So just anybody can't go walking in and out of that maternity ward, okay? And that's when they take the baby's little teeny tiny footprints that they put on the birth certificate. There are 2 birth certificates, right? There's the record of birth from the hospital that has the baby's little footprints on it, right? Very cute. That's not the official birth certificate. The official birth certificate is when they come into the room and ask the mom, what's the baby's name, right? Make sure they get it right, spelled right. What's mom's name, dad's name, all that good stuff. And that comes to the mom usually through the mail, right? And it's it's got a seal on it, from that whatever county that they live in. Okay. Okay. I beat the PowerPoint. I didn't know that they talked about it, but they do. Completing the birth information and the health record, right? What's the gender? What time was the child born? What type of delivery occurred? Did the kid have any identifying marks? Eye care. And I hope everybody knows what we mean by eye care. So let me just elaborate. When that baby goes through the vajayjay, there's just a lot of gunk. Imagine your eyes. Ooh. So we're going to put usually erythromycin ophthalmic ointment. I'm going to put here antibiotic ophthalmic, ointment. Okay. It's usually erythromycin. It doesn't have to be erythromycin. It's usually a broad spectrum. And erythromycin is just the most common one that they use. Baby's going to get its first taste of welcome to the world, kid, shot, right? Baby's going to get vitamin K, right? It's an IM injection in the vastus lateralis. Okay. And then also we know now what the baby's blood type is. So if mom is negative and the baby's positive, mom will get her second RH shot, her RhoGAM shot. Is the following statement true or false? A newborn with the APGAR score of 8 at 1 minute does not need to be reassessed at 5 minutes. No, that's false. So even if that kid has a 10 at 1 minute, you always reassess the baby. We always do 2 of them just in case, because there could be a decline. It's not typical, but it could happen. So you always do the 1 minute and the 5 minute. Okay. Okay. So again, protection against disease. Standard precautions are always used, of course, that's standard precautions is the same as universal precautions. They mean exactly the same thing, right? That's running under the assumption that everybody has something and whatever they got, you don't want, right? So if you're going to be in contact with body fluids, you're going to be wearing gloves. If there's going to be splatter, put on goggles, put a gown on, right? Clinical judgment to decide what PPE you need based on what kind of task you're doing, right? Eye prophylaxis, we talked about that. The word prophylaxis means preventative, right? So preventative, and that's that ointment, that antibiotic ointment to prevent newborn conjunctivitis. It's conjunctivitis neonatorium, if you want the exact term. Vitamin K administration, and the vitamin K for the baby is simply because they have a tiny little immature liver, so they don't have a store or a stockpile of vitamin K. And we want to make sure that there's no hemorrhage. Remember, they just were connected via their cord to the mom, right? So there's always a risk of bleeding. So the vitamin K just gives them a little bit of a boost. And vaccinations. Before the baby leaves the hospital, if the mother is hepatitis B negative, then the baby will get just its first hepatitis B of the series of 3. Okay. And I'm going to add this in here. So the baby's going to get its hepatitis B first injection. And that's also in the vastus lateralis. That's IM also. Okay. If mom is hep positive, and I'm going to put this here, if mom is hep B positive, then neonate needs HBIG? What's the acronym? Right. So it's the immunoglobulin for hepatitis B. So in other words, to help that baby not get the hepatitis B that mom has, right? So that's the actual immunoglobulin. So if the mom's hep B positive, baby will get 2 shots. If the mom is not, the baby will just get its standard 1, the first injection of the series. And then the pediatrician will do 1 at 1 month later, and then 6 months later. That's how the hepatitis B series. So let me do that here too. 1 month later is the second, and then 6 months later is the third. Okay, that's your standard hepatitis B. Okay, promoting that bonding that I was talking about, that parental bond. So you want to encourage mom to attach or bond with the baby, touch it, hold it, all that kind of stuff. There's certain behaviors that you see with mothers typically. The mother stroking the baby, touching the baby, rubbing the baby. Usually they'll be like looking at the baby's hands and feet. Does it have 10 fingers? Does it have 10 toes? And all that good stuff. And usually it's the cutest thing, but usually if the baby's laying on the chest, mom will look down and baby will look up. Because remember, baby's been inside for 9 months, hearing mom's voice. So they already are connected. So baby knows who mom is. So she recognizes the voice. And I don't know why. Why do we talk to babies like this? Oh, you're so cute. I mean, I never did that. I talk to my kids the way I'm talking to everybody in this class. And they're very articulate as adults. I don't know if that's why, but it used to annoy me. My own personal opinion does not reflect the opinion of AHE Schools nor any of its affiliates. There's my disclaimer. But yeah, I always talk to my kids from the time they were babies. What do you want, sweetheart? Tell mommy what you want, like in a normal voice, not, okay, honey. Again, just my opinion. All right, what's a newborn supposed to look like? So weight, usually 5.5 pounds to 9.5 pounds. Average full-term babies about 7.5 pounds. Okay. Length is anywhere from 18 to 22 centimeters long, and that is genetic. If mom and dad are short, guess what? Probably short baby, right? Mom and dad are tall, or somebody's tall, might be a long baby, right? Head. The head is big. Babies are funky looking. They all look like Winston Churchill, I think, when they're born. But they have a big old head, right? Usually 13 to 14 inches in circumference, and we measure the circumference of their head. And the head's going to probably be a little molded. because of the events of labor. So you're going to have a bit of a cone head. It's temporary, right? That resolves on its own. Excuse me. And then you have a couple things that could be problematic. So the cephalohematoma, I think I talked about briefly before, but I'm going to start at the bottom and talk about that one. During the birth process, what can happen is the baby can actually get, it's a bruise. A hematoma is a bruise, right? So it looks like a black and blue kind of lump. And I am actually going to pull pictures and put them into this PowerPoint. So let me do this. And this I think will help everybody. I'm adding a slide and I'm going to go to the good old internet real quick. And I'm going to pull up cephalohematoma. And let's try to get a good picture of one. That's a bad one. Here, let's see. Excuse me. Here, this is a good one versus the Kaputzidinium. All right, so I'm gonna see if I can't copy this picture. Copy image. And let us see. Look at that. It's like magic. And this is a good picture. This gives you kind of an indicator of the two different issues. So cephalohematoma, right, is basically just a big old bruise, right? And it's going to resolve, but it can look a little scary if the baby has one. That usually happens with assisted delivery. So in other words, forceps or vacuum assisted delivery, just because it's kind of like pressure on the head, right? And the Kaputzidinium, it's a hard word even for me to say, see, is a little bit more than just a bruise. It's like it's right by the suture lines, okay? And it's where, again, usually this is because of a vacuum assisted delivery. It's the most common reason. So vacuum assisted delivery, it's like almost like a suction cup kind of a thing that goes onto the baby's head, the top of the head, but away from the fontanelle. So there's a fontanelle here, and there's anterior and a posterior fontanelle. Can't go near there. So you go right about here, and it uses like suction to help. So as mom pushes, we're trying to like help her. Sometimes if the pushing is ineffective, right? But it can actually cause a little bit of damage. So those are the kinds of things that can happen during the delivery process. The molding, I'm not even going to talk further about because that just resolves on its own. If the kid's a cone head, it won't be a cone head for long, right? It has to be. So this way, that's why the fontanelles are there and the suture lines are there, because the brain, the brain's protected, but there's still room for it to mold. So it doesn't crack its skull open going through the birth canal, right? Pretty amazing. Okay, fontanelles are the soft spots, we call them, okay? The anterior fontanelle usually closes between 12 and 18 months. That's the slow one. That takes a minute to close. But the posterior fontanelle should be closed by the third month. They all look like Winston Churchill. They have a little face, kind of a flat nose, ears, kind of a receding chin line, like the top of the ear, the pinna of the ear, right? The top of the ear should be at or above the line of the inner canthus of the eye. So do you see how the top of the ear, this is the inner canthus of the eye. See how there's a line, imaginary line, and they're level with each other. If they're not, and we'll talk about that when we go to complications in the baby, there could be a problem. Okay. But that's what it should be. That's the norm, as much as I hate the word norm. And the fontanelles are important for lots of reasons. I'm just going to add this in right now. If a baby is becoming dehydrated, you will see a sunken fontanelle, right? And if a baby has excess fluid, you can see a bulging fontanelle. So it's, bulging out, okay? All right, next we've got Body. The chest is about 10 or 12 inches in circumference, and they measure the chest. Usually when that baby's born or when it starts to cry, mom's breasts will go and fill up, they'll engorge. When you look at a newborn's genitalia, for the female, it's going to be swollen, right? The labia that looks kind of swollen when it's first born. And it's just because of the mixing up of mom's hormones with baby as baby's born, because the blood gets kind of mixed back and forth. Same thing with a boy, right? So we'll talk about hypospadias and epispadias. That's where the urethra is in the wrong spot on the penis. And that's a problem, right? So normally the urethra should be at the very end of the penis, right? With hypospadias or epispadias, it's in the wrong location. It could be underneath the penis. It could be close to the testicle. It could be anywhere, just not in the right spot, okay? Skin. When a newborn is born, hopefully they're a little pink from crying. But if they're cyanotic, remember, hands and feet can be blue. That's acrocyanosis. That's normal because they're usually like this, clenched, right? But the arms, legs, body shouldn't be blue, right? Because that would indicate a lack of oxygen. So it should be a pinkish color. And depending on the ethnicity, right? Its skin color will start to become whatever it's going to become based on its ethnicity within a couple of weeks, right? Acrocyanosis I talked about. Desquamate, bumps, rashes, other more. Lanugo, vernix caseosa. So vernix caseosa is that white, creamy, cheese-like gook that's all over the baby. That's almost like a protectant, protects its skin. It's waterproof. I mean, tell me the body's not amazing. It covers the baby in this waterproof stuff because it's in fluid for 9 months, right? So the skin doesn't get ruined. Lanugo is that fine hair. Sometimes babies, all my babies were hairy too. I'm Italian. So hair on the ears when they're born, sometimes hair on the back, right? And it falls off little by little. Milia are little, like usually you'll see them on the baby's nose. They look like little white bumps, normal. Erytheum neonatorium toxicum is a rash that a newborn can have. Not a major problem, but it almost looks like almost like an acne, like a red rash that it can have on its face or torso. We'll talk more about problematic, like if there's a dimple at the sacral area, that's a problem, right? So we'll talk more about that when we get to the abnormal findings, but these are all normal or expected findings. Okay, all right. Movement and activities. So they're not blind. People say, oh, newborn can't see. No, they can see, but it's just kind of fuzzy, right? The first couple of weeks. And they can see light and dark. They can hear and they can feel, of course. And it depends on the maturity of the fetus. So if the fetus is premature, it goes to show that it would not have necessarily the same level of senses as a full term, 38 to 42 week fetus. There's the babies. So reflexes that you must know. If you take your finger and you touch a baby's cheek, it'll turn towards that finger. That's the rooting reflex. Okay. That's the rooting reflex. And that's important because the kid needs to eat. Don't let it starve, right? Reflexes. Let me put it here. Rooting, right? And the baby, if you put your finger or your hand, the baby, they'll take his little hand and hold onto your finger. It's so cute. And actually, I don't remember what that one is called. Anybody know what that one's called? I think it's the grasp. Yeah, I think it's the grasp. And hopefully we go over the Moreau and the fencing. Yeah, this is my favorite, the Moreau startle reflex. Absolutely cracks me up. I don't care how many times I've seen it, a gazillion times. Funny every time. You can either go, near the kid, loud clap, or if you're holding the baby, you can kind of go down and the baby will go. Funny every time. That's the Moreau startle reflex. So let's put that here. And then this one, that's the fencing reflex. That's like the kid looks like he's trying to dance, right? So if you take the baby's head and gently turn it to a side, one side or the other, when you turn it to the side, the baby's arms and legs, it's like it's dancing. So that's the fencing reflex. And then hopefully we have the Babinski. Yep. Right. The Babinski's fun too. So you take either your finger or you can take, like a pen light or something on the baby's foot at the medial aspect of the heel, right? Medial aspect, the inner aspect of the heel, up towards the great toe. And you just go, as you go up to the great toe, all the little toes will open up and fan out. That's the Babinski. That lasts until the kid starts to crawl. Once they start crawling and they're getting ready to walk, that should disappear, right? And it's totally abnormal in an adult. It's a bad problem if you have a Babinski reflex in an adult. That's a sign of a traumatic brain injury, right? That's not good. So we've got Babinski. And then this is always fun, even though, they're not going to do it, but it seems like they're trying to walk. If you hold them and just let their feet touch a surface, they look like they're trying to walk. And again, that's just a reflex, and that actually goes away when they start to crawl. And they should crawl by about, again, there's milestones that we will go over for babies, and every baby is different, but there is a window of what we consider to be average, right? Of when babies should start doing things, like rolling over and crawling and all that good stuff. Okay. And that's called the stepping reflex. Put this in here too. Babinski and then step reflex. Okay. Is the following statement true or false? The posterior fontanelle should close by the 18th month. That's posterior fontanelle closes by about the 3rd month. Yeah, that one closes quickly. Yep. The anterior one is the one that takes a little longer to close, slower. Okay. So all this information has to be documented. The length of the first stage and second stage of labor. Did we rupture the membranes or was it spontaneous? How was the baby delivered? Was it difficult or easy? Did we have to use any assistive devices like forceps or vacuum extraction? Did mom have analgesics or any kind of anesthetics? What was the newborn's condition at delivery and the APGAR scores? All of that needs to be documented, right? And also, did the kid need to be resuscitated? What were its vital signs? Did we give it its vitamin K? Did we give it its eye prophylaxis? Did the baby void or whether or not the baby voided or passed the meconium plug or stool? I don't like the way that's worded, but okay. So meconium is the baby's first bowel movement, and it's kind of gross. It's a blackish green, tarry looking poop. Usually it'll happen within a couple days after delivery, but sometimes, and this happens especially with post-term babies. So in other words, if mom's like 41 weeks, right, 42 weeks, sometimes the baby will have its bowel movement in utero. And that's very, very dangerous. That's an emergency actually, because if the baby's going, because its mouth is open in the amniotic fluid. And so that meconium, it will ingest it. And that's basically poison, right? So the umbilical cord, 2 arteries, 1 vein, just ignore that. 2 arteries, 1 vein, AVA, right? We're going to weigh the baby and measure the baby. And all those measurements I talked about before, the chest circumference, the head circumference, the length of the baby, the weight of the baby. Vital signs. And the baby's going to have vital signs taken usually about every hour for the first few hours, and then every 2 hours for the next, like usually 6 to 8 hours, just to make sure that everything's hunky-dory. Respiratory status, it's normal if the movements of the diaphragm and the abdominal muscles are synchronized. In other words, it's crying, everything should be synchronized. There shouldn't be abdominal retractions. So when you breathe out, when any human being breathes out, the diaphragm lifts to help compress the lungs to breathe out. With abdominal retractions, it's the opposite. The baby's breathing out and you'll see the belly bulge, right? And then sink in when it breathes in. That's not good. That's a sign of respiratory distress. Crying's good. You want the newborn to cry. But when will it cry? Sometimes just to torture you. No, I'm kidding. When it's hungry, when it's wet, if it's uncomfortable in any way, right? Because babies can't talk. So the only communication they have is to cry, right? So sometimes they will just cry. First, first urine, 24 hours or so, within the first 24 hours. First stool, usually within 12 to 24. And it's black, green, tarry, liquidy. It's gross looking. All right. Signs of respiratory distress. A lag on inspiration or a seesaw movement. So if the baby's like it's gasping, a lag on inspiration, that would be a problem. Intercostal retraction. So the intercostal spaces are the spaces in between the ribs. So the retractions, like I said, it's an indentation where the baby breathes in and I can't even make myself do it. It sinks in. Okay. And xiphoid retraction. The xiphoid process is right by the sternum. Same principle. If it goes in, not good. If its nares are flaring, like it's struggling to get air, respiratory distress, or expiratory grunt. Kind of sounds like that. It's the best I can do. All of those things are worrisome. They would be signs of respiratory distress. And pediatrician is going to come in. So usually you'll pick your pediatrician before delivery, and the pediatrician will come in and we'll do a head to toe assessment on the baby. Within 24 hours, they'll look at the chart to see what the delivery was like. And whatever the nurse wrote is also very important because the pediatrician is going to be looking at that as well, to refer to. Got to keep the kid warm. So that's why it's important when the baby gets home, never put a crib near a window, never put a crib near a heater or, a heating source or air conditioning source of any type, right? You want to keep it, they call it a neutral thermal environment. In other words, somewhere about 75, 76 degrees is a good neutral, right? But again, some people go crazy and they'll have the baby wrapped up and like it's 85 degrees outside, like unwrap the kid. If you're sweating, then the child is probably hot, right? Kind of use that as a gauge, okay? Automatic sensor tape to the abdomen. Right, that's when that's like the first couple hours after birth. And thermostatic control. Love these PowerPoints. When they put the baby in the bassinet, the little rolly thing that they roll, because never, ever, ever will the baby be hand carried from a nursery to the mom or vice versa, right? Always have to put that baby in the bassinet. And the reason for that is to maintain that security that I talked about earlier because of, people stealing babies and that type of thing. Somebody might come in and say, yeah, I'm the aunt, and then out the door she goes. So those little bassinets, they put like a warm blanket underneath and that'll keep that mattress warm. If the baby has a problem with heat regulation, then they'll put it in a warming bassinet, which is different. It's got a radiant heater that can constantly maintain a temperature for the child, like around 76 degrees. Cleansing. All depends on where you have your baby, right? Normally the nurses, we used to clean the babies off and then, first we let them skin to skin, then we take the baby, clean it, make it nice and pretty, and then give them to mom, right? Some places now have birthing suites, and if dad wants to do it or mom's girlfriend, if they're lesbian or whatever the case may be, significant other wants to do it, they can do it, as long as they're not holding the baby by its feet or something crazy. You don't want the kid to get chilled. So when you are bathing a newborn, it's important the head gets washed last, right? And the head's going to need to get washed because when it's first born, it's gunky, right? But the body first, wipe the body down, sponge bath, wrap it up nice and warm. The head, then put the little cap back on it to keep the heat in. Labs, normal labs, and these are important. So labs for babies are very close to adults in a lot of ways, okay? So what labs are we going to draw? And remember, drawing labs from a baby, it is a heel stick, not a venipuncture like you do with an adult. Going to keep that foot in a dependent position, warm it sometimes just to make sure you're going to get the blood. And it's more like a little scalpel, right? The little thing that we use, and it just goes, makes a little line, and then you squeeze the blood into your little tubes and it goes to the lab. Hemoglobin, right? 15 to 18. What's a normal hemoglobin for adults? 12 to 18, right? Hematocrit, 45 to 60%, same ballpark as adults. Blood sugar, little different, 40 to 45 when it's first born, but then 60 to 100, just like us, okay? We're going to talk about PKU, galactosemia, thyroid function, sickle cell, maple syrup urine disease, and glucose 6-phosphodehydrogenase deficiencies. And they're going to try to get a urine sample also from the baby if they can, just to make sure everything is right. But standard testing, they're always going to do an H&H. H&H is hemoglobin and hematocrit. That's standard. And they're going to do a blood sugar. And especially worrisome if the baby's macrosomic, because they typically are hypoglycemic. And these other things we'll talk about, you know, these are the things that can go wrong with a newborn that would be problematic. We talked about the security and the identification. Sleeping position. When my children were born, they said, only put the baby down on its belly. That's the only safe way for your baby to sleep. On its, and I had bumper pads in the crib and stuffed animals in the crib and blankets in the crib, and they're all not, they're still with us. But now you are to have absolutely, and I'm not even playing, nothing in the crib, right? Not even a blanket. If it's cold, put those onesie jammies on, right? So no blankets, no stuffed animals, no bumper panels or whatever, bumper pads, right? That they had before. None of that because of the risk of sudden infant death syndrome, SIDS. And always on its back. Baby should always be placed down in a supine position, never prone. When it starts to roll over, it'll put itself in that position, you know? So if it wants. Newborn care, I mean, vital signs, basic needs, how to handle the newborn, always support the neck. It's got a floppy head, you know? So you want to make sure you protect the head, the neck, protect the fontanelles, right? That's all very important. Babies love to be swaddled. Swaddling is the best thing for babies. And they'll teach you how to do it at the hospital, where you take one of those receiving blankets and you wrap the kid up like this, real tight, and it's like this, but it loves it because it's been like that for 9 months inside of you. Cord care. We used to put alcohol on the cord stump to dry it out. Routinely. We even did it at the hospital, right? But we don't need to do that anymore. So just at the air and make sure the diaper is tucked under the cord stump. So you don't want anything on the stump of the baby. And there's no special care for the genitals unless there's a problem. And the swelling that you will see will subside on its own. And that's just because of the hormones, right? Mom can breastfeed, she can bottle feed. It's, you know, her choice. For a newborn, on-demand feeding is better than scheduled feedings, right? Although it can be very tiresome. On-demand means that whenever the baby goes, you feed it, right? Put something in its mouth and make it stop. Facilities are different. Most facilities now, the baby stays in the room with mom. When I had my babies, the baby went back to the nursery so I could sleep a little bit, which was awesome. So, assist the mom, encourage proper hand hygiene, teach them. I never heard burping called bubbling before. So, but okay. How do you burp a baby? There's several ways. One way is over the shoulder, gently pat the back, right? Sometimes rubbing the back helps. Or for me, what always worked is I would put the baby over my thigh and rub its back. And usually that worked like a charm. Supplements may be suggested. It all depends on what type of feeding, if it's breastfed versus bottle fed. If it's breastfed, sometimes they'll give you iron drops to give to the baby supplement. If it's bottle fed, all the formulas are fortified. So they have everything that's needed. Yes, breastfeeding is better. Yes, of course it is. Better nutrition. I mean, it's all natural. The baby's going to have antibodies from the mom regardless, just to be clear. Okay. That happens through the exchange of blood that occurs through that umbilical cord. So the baby is born with passive immunity, naturally acquired passive immunity, which means it's immune to everything mom's immune to, but only for a minute. It's temporary. It's going to wear off. And so that's why we start giving baby immunizations right away, right? Breastfeeding is good because it's often breastfed babies don't develop allergies. Breastfeeding helps bonding, helps with the involution or the contracting of the uterus back down to its pre-pregnant state. Not necessarily delayed ovulation. I will say no to that one. And I'll tell you why. So you don't necessarily get a period right away after you have a baby. And if you breastfeed, oftentimes you still will not get a period. But that is not a guarantee that you're not ovulating. There are many people that have 2 children that are very close in age because of that issue, where they go, oh, I have no period. I can't get pregnant. Surprise. You absolutely can get pregnant. So I will not agree with this delayed ovulation, not accurate. The breast milk is the right temperature. You don't have to worry about warming it up. That's nice, right? It's always available. Store's never closed. Convenient, I guess, for the baby, maybe not for the mom. And it's free. You don't have to pay for it, where formula costs money. So there are, benefits. The things that have to be considered, people say, well, anybody can breastfeed. It's all natural. Sometimes people have trouble, right? The baby has to latch, and that whole mouth has to go over the entire nipple, areola and all, like the whole thing. I cringe when I think about it. I bottle fed. So, they have a charting system here that looks at the efficiency of the mother's ability to breastfeed. And they look at the latch, the swallowing, and the type of nipple. People used to say, well, if you have inverted nipples, I don't know if you guys know what that is, but an inverted nipple, instead of the nipple sticking out, it's pushed in. And it happens. Nothing's broken, right? The nipple still works. But if it's an inverted nipple, it sometimes is harder for the baby to suck, because it's got to not only latch, but it's got to get that nipple to pull out. So it can be problematic. Or a flat nipple. It's not pushed in, but it's just flat, right? A regular nipple should be right out. Can you hear the child swallowing? Right? That swallowing sound. And how's it latching on, right? And it gives you the specifics here, tongue down, lips flanged, like that. And rhythmic sucking. Okay, so all that stuff. The nipples should not be painful. If the nipples hurt, probably the kid is not latching on appropriately. And the hold, usually there's a way that you can hold the baby that's easy for mom and baby. Now they make these boppy things, they call them. It's like a pillow to help keep the baby in the right place. You're going to provide education. The letdown reflex is fun, right? The letdown reflex. So if you could be out and you left the baby with somebody, with dad or somebody, and if you hear another baby cry, your milk is going to go, it's a mess. Another reason why I didn't want to breastfeed. It's common for women to have sore nipples or cracked nipples, or to engorge occasionally. Plugged ducts are not common, but they can happen. And mastitis, not common, but it can happen. And that's an infection, right? That can happen to the breast. And if mom's going to breastfeed, anything, everything, anything that mom puts in her body is going to go to the breast milk. Anything, everything. Tylenol, vitamins, crack, heroin, anything that mom puts in her body, right? Cigarettes. Another reason why I didn't breastfeed, I wanted to smoke again. I didn't smoke for a long time. So, and I wasn't going to make the baby smoke. That's not fair. Let him figure it out on his own when he's 14, like I did. So So mom has to eat appropriately too, right? That's the other thing, and drink plenty of fluids in order for her to produce the milk. Um, I keep beating this PowerPoint to the punch. That's the next slide. Drugs that are dangerous to the nursing newborn. So any type of chemotherapeutic drug is dangerous to people. Forget about a newborn. Any radioactivity is dangerous. Lithium is dangerous. Any drugs that, when they say drugs of abuse, they're talking about, crack and heroin and whatever. They say these drugs are generally considered compatible. Acetaminophen in small doses is safe, right? But you would never exceed 3,000 milligrams in a 24-hour period. Antibiotics, the broad spectrums like penicillin, amoxicillin, erythromycin, generally safe. Codeine, phenytoin, and pseudoephedrine. I am going to leave that one alone simply because codeine is a narcotic. Phenytoin is Dilantin. It's an anticonvulsant drug. Pseudoephedrine is an antihistamine that you actually have to sign for at the pharmacy because people use it to make crank meth. So I don't know that they're considered compatible, but I will look it up. So I'm going to just leave this slide alone, slide 46. Wash your hands before you touch the kid, or don't. Keep the nipple of the bottle clean. They tell you to sterilize the bottles in the beginning, right? And so you can just throw them in the dishwasher because that's hot enough to be sterilization. Always tilt the bottle so the kid's not swallowing air because you're the only one that will pay because the baby will cry and cry and cry until it burps. And you warm the bottle. Never warm the bottle in the microwave, right? You take a pot of hot water. Now they have baby bottle warmers, but in the old days, we took a pot of hot water and we stick the bottle in the boiling water and we would wait until the formula got warm to give to the baby. Before they send the baby home, make sure everything is good. They're going to take one of the bands off the baby and stick it in the chart, but they're going to leave the other one on the baby and the mom until they're out of the hospital, just to be safe, right? And they should be in a rear-facing car seat, and they're going to come out and check before they let you leave the hospital. It's like the Nazis at the hospital. Do you have everything that you should have? Question: a bottle should not be warmed in the microwave. I think I just said that, didn't I? And the end, right? Okay, well, that was fun, guys. So I'm going to stop this and stop the recording.